It's truly a privilege for me to introduce this distinguished panelist whose work has been of great benefit to the people I serve in the 11th Congressional District. I'm very honored today to introduce Dr. Linda Brady. She's currently the president and the CEO of Kingsbrook Jewish Medical Center, located in Brooklyn, New York. Dr. Brady has served in her current role at the medical center since 1999. A cum laude graduate of Barnard College, Dr. Brady received her medical degree from New York University School of Medicine and completed her psychiatric residency at the Albert Einstein College of Medicine, Bronx Municipal Hospital Center. Kingsbrook Jewish Medical Center, located in the East Flatbush section of central Brooklyn, was founded in 1925 as a chronic care facility to serve the then Jewish community within a cultural context. As the community diversified, Kingsbrook expanded its services and programs to meet community needs. An 864-bed medical training institution, Kingsbrook comprises a 326-bed acute care hospital and a 538-bed adult and pediatric skilled nursing long-term care facility. Today, Dr. Brady is here to testify on behalf of the American Hospital Association. The AHA is the national organization that represents and serves all types of hospitals, healthcare networks, and their patients and communities. Close to 5,000 hospitals, healthcare systems, networks, and other providers of care, and 37,000 individual members come together to form the AHA. I am proud to have Dr. Brady here representing my district. I am grateful for you being here today, and I look forward to hearing your testimony. Thank you very much, Madam Chair.
Welcome, Dr. Brady, and you will have 5 minutes to make your presentation. Thank you.
Good morning, Madam Chairwoman, Ranking Member, and hello to Congresswoman Clark. I'm Dr. Linda Brady, President and CEO of Kingsbrook Jewish Medical Center in Brooklyn, New York. On behalf of the American Hospital Association's nearly 5,000 member hospitals, health systems, and other health organizations, and its 37,000 individual members, I appreciate the opportunity to share with you the administrative burdens faced by hospitals and what should be done to reduce them. As a valued and trusted public resource, our society holds hospitals in special regard. As a result, we are closely monitored and evaluated by local, state, federal, and private regulators charged with protecting the public and ensuring that public funds are spent wisely and in the public's best interest. However, providers are increasingly concerned that healthcare regulation is out of control and has lost a sense of fairness and common sense. Currently, administrative costs comprise between $145 and $294 billion of our nation's healthcare spending and are a chief factor in the growth of that spending. It's time for a dramatic change. Should all regulations be eliminated? No. The issue is not whether to regulate, but how. Just as providers constantly work to ensure that what they do benefits patients first and makes prudent use of resources, government must do the same by standardizing requirements, being efficient in its demands, and eliminating some of the redundant administrative burden placed on providers. Hospitals operate in an increasingly constrained financial environment. As a result, every dollar is precious to preserving our mission. Medicare currently reimburses hospitals only 91 cents for every dollar of care that they provide to a Medicare patient. And Medicaid payments are worse, only 86 cents for each dollar of services. In 2006 alone, this combined underpayment totaled $30 billion. That's on top of an additional $31 billion in uncompensated care. Meanwhile, more and more of hospitals' precious resources are being diverted to comply with inefficient, duplicative, and burdensome regulations. Nearly 30 federal agencies regulate hospitals, and little coordination exists among them or between similar agencies at the state and local levels. As a result, redundancy abounds. For example, CMS conducts 6 types of activities to protect against improper payments, waste, fraud, and abuse. Multiple contractors are tasked with carrying out these activities to one degree or another. While each contractor has an individual purpose, they often seek the same information, requiring duplicate effort by hospital personnel who must pull review, and process patient charts and appeals time and time again. The Medicare Recovery Audit Contractor Program is particularly troublesome because the RACs are paid on a contingency fee basis, meaning they keep a percentage of the payments they recover with limited risk for making the wrong decisions that unfairly hurt providers. This bounty hunter-like payment mechanism has led to excessive chart requests and aggressive denials on the part of the RACs. Kingsbrook, for example, has seen many cases of wound debridement denied for incorrect coding. In 119 cases, the RAC claimed that we used the improper code because the word excisional was not written on the patient's chart. However, the charts contained skin biopsy results, clearly demonstrating that skin had been removed for testing. The RAC was unwilling to accept clinical addenda to the medical record, despite the fact that every medical and legal expert we consulted said that such documentation was sufficient to make a determination. As of December 31st, 64 cases totaling $894,000 have been overturned in our favor upon appeal. 15 cases are still pending. The cost to us in terms of money and man-hours expended to overturn these erroneous denials and recoup money that was rightfully owed us was great. And yet, we continue to be subjected to denials for the same documentation issue because the RAC program lacks a feedback loop. This example only hints at the levels of confusion and waste caused by duplicative oversight mechanisms. In conclusion, we urge the administration and Congress to work together to ease the regulatory burden confronting healthcare providers by creating a more common-sense approach to developing and issuing future regulations. Equally critical is the need to provide relief from the most burdensome, inefficient, or ineffective regulations, those that take away critical time spent with patients. My written statement contains specific actions the AHA believes will help ease this burden. Hospitals are committed to doing the right thing the first time to ensure quality, patient safety, and payment accuracy. However, duplicative regulatory and oversight mechanisms only increase confusion and drive up costs for both hospitals and the healthcare system as a whole, as well as for the government. We need smarter, more efficient regulation rather than additional rules and oversight so that the people of America's hospitals can spend more time with patients and less time with paperwork.